So, greetings, good morning, good afternoon to everyone joining us today. Welcome to the 8th installment of NCIHC's On the Road webinar series. We anticipate a full house today. We've had hundreds of folks register from all over the country and from all over the world. So, wherever you are, we welcome you. And we look forward to having this 90-minute panel conversation on the theme evaluating the potential use of AI-generated interpreting in healthcare. We'll give folks a few moments to join. We encourage you to use the chat to connect with each other. It's always wonderful to see where we are, to send our greetings. This is always a very warm and welcoming group. We encourage folks who have questions for panelists to use the Q&A box. If you put your question into Q&A, we will see it, and we may be able to work it into the conversation. We cannot promise to answer every question live, but we do promise that the panelists will see your questions, and we'll do our best to respond to the ones that we can live, and maybe even provide some response to some questions offline. This is the 8th installment of NCIHC's On the Road series. We welcome all language access stakeholders to these conversations. The primary target audience for On the Road has always been healthcare administrators, people tasked with building their language access infrastructure within their healthcare organizations. And the topics we address are meant to help us understand better how to do that, what's needed, how to go about it, what other health systems are doing, and where we might want to have caution, what things we might want to consider in the different aspects of building our programs. As I mentioned earlier, today's conversation will focus on evaluating the potential use of AI-generated interpreting in healthcare. We have three wonderful panelists today. We have Cindy Rote, who among many roles is a board member with NCIHC and had the pleasure of announcing this summer new guidance for healthcare organizations evaluating the potential use of AI-generated interpreting. We have Catherine Allen, who among many things is a founding member of the SafeAI Interpreting Task Force, which is the first ever group of language access stakeholders to come together and look at the potential use of AI and how to do it safely in all of the branches of the interpreting field. And we have Chris Kerwin, who is the Director of Interpreter Services at Massachusetts General Hospital and the President of the Board of Directors for the Forum on the Coordination of Interpreter Services, which is a nonprofit group that supports folks who run language access programs in hospitals and clinics. It's a group for networking and for the sharing of resources. So thank you three for joining us today. As I mentioned earlier, we encourage folks to use the chat to share their comments and impressions, to connect with each other. We ask respectfully that folks refrain from using the chat to advertise any specific products today. We really want this to be a vendor-neutral setting in which to discuss the concepts around AI-generated interpreting in healthcare. The chat is wonderful. It's going to be fast-paced with hundreds of folks participating. Sometimes it can be a little bit overwhelming. It's also okay to close the chat and just focus on the conversationalists. These are three amazing people with very unique qualifications. This particular conversation has never been had before. We've never been in the same physical space or the same virtual room. So it's okay just to focus in on the conversation too. And hopefully that will feel a little less overwhelming than the comments coming through chat. So let's start off with a poll question. Salma, our wonderful administrator, is going to bring up a poll. And the poll is asking folks who administrate hospital language access programs, to what extent is your health system using AI-generated interpreting? There are some options here. Have you piloted or implemented an AI-generated interpreting product? If so, let us know. Are you considering an AI-generated interpreting product? Are you opposed to the use of any AI-generated interpreting product? Or are you not sure? All of these are valid responses. Please take a moment to pick the one that best applies to your program and your health system as you understand it. and we will display your responses very, very briefly. If you're not working in a hospital or health system, or you're not running a language access program, it's okay to sit this one out, but we wanted to get a sense of to what extent are hospitals and health systems involved in this conversation, piloting or implementing or planning to pilot or implement AI-generated interpreting in the near future. So how are we doing for responses, Salma?
So we've got 51% responded so far.
Fantastic.
And the highest response is for D. I am not sure.
I'm not sure. And this is a great place to be. Thank you very much for sharing those responses. So most of us who are working in healthcare are really not sure what our health system's next steps might be when it comes to AI-generated interpreting. So let's focus now on that concept. What is AI-generated interpreting? AI by AI, and how is it different from AI-assisted human interpreting? Catherine, talk us through this.
So Amit, welcome everybody. It's really great to be here. I really appreciate the invitation to be here and to sort of participate in this next wave of change that we're all coping with. So just to try and get us all on the same page in terms of terminology, the term AI by AI is one that has been suggested from the work that the SafeAI and Interpreting Task Force has been doing, and it stands for Automated Interpreting by Automated Intelligence. I think it's unclear whether this will take, I mean, we'll just see if this becomes a use term or not. It is useful though to think about, it is, to me, I think it's useful as just sort of like automated interpreting is a nice term that covers a broad swath of, how this technology is coming into our space. So when we think about what automated interpreting is, I think let's just start for a minute and think about the kinds of automated machine translation that we may all be familiar with, such as when we're on a Zoom call and there's automatic captioning, right? I mean, that doesn't have a human behind it, where the technology is capturing the audio and turning it into an English feed. Like we all have seen this, including on the movies we watch at times, or the news feeds or the YouTube channels. So when you think about automated interpreting, the first level really is a written form, and that would be multilingual captioning. So the difference is that you're adding in the translation layer. The technology is capturing the voice. It is creating a transcript. It is running it through a machine translation to get it translated into the desired language, and then it is producing the automated captioning in those different languages. So, it's real, but it is real time. I include it in the automated interpreting because it's being used for real time communication when people are speaking in the moment. It's not a translation that can be reviewed, or fixed. And then you get up into the level where you add on an automated speech at the final step. So you are able to then take that multilingual captioning content, and then it's put out as a virtual voice. And we've all now heard these AI voices at this point. So when you think about speech to speech interpreting that's fully generated by artificial intelligence, it is, it seems as if it's listening. You might have an avatar. You might actually have a human being that's fake that's then talking as well. And you'll be seeing, in the background, what it's doing is taking that automated sort of that translation and then putting it up into an audio format in different languages. And I think we all know that it really depends on the language pair for how well that works. And it also really depends on how good the audio is for the initial capture. So those are some of the things to think about that. So then when we talk about AI assisted interpreting, to me, this is all of the ways that an interpreter can use AI to assist their human performance, whether it's ahead of time using AI tools for their preparation, which is a hugely promising and wonderful way to boost our preparation. This is where it's most happy. I think these tools can be really amazing. You might have it in training as well, but interpreters are also using AI to assist their interpreting, especially in simultaneous interpreting in the conference side. First, in how to layer in, I'm reading this captioning and I'm using it as I interpret. And it is a whole nother cognitive skill set. But there are a lot of conference interpreters using simultaneous to do that. And they may also be using AI tools to grab, for just immediate glossary generation while they're interpreting, especially if it's consecutive, right? And they may be helping to use it with their note taking. So it can assist in the interpreting. I think we're in pretty early days on figuring out what the best ways for that to work. And I guess I would just close by saying, for this audience in particular, there's two things to consider. One, there are many, many ways these tools can come into healthcare that go well beyond the patient-provider interaction. So they may be an excellent tool for communicating with your multilingual staff, but not a good tool for communicating with a patient. But they do have promise in expanding access. So there's lots of different areas that this can come in. And then the other thing I would say that in the healthcare setting, of course, for the most part, people are treating it with a lot of white gloves because it's a regulated space and because of the jeopardy of messing up, the healthcare communication. So I think I'll end there. And then if any of my colleagues want to add on something that they think needs to be highlighted, please do.
Well, I want to thank you for making the distinction because in this particular conversation, we won't be focusing on human interpreters using AI tools for a better interpretation. I do see in the chat that there are interpreters saying, I do use these tools, or I look forward to using these tools, and that's great. It's an exciting new frontier to think about all the things we can use to make us better interpreters. But this particular panel is talking about the AI-generated interpreting. So the AI by AI without human involvement in the real-time production of the interpretation itself or the message itself. And that's a very specific topic. So I'm really happy, Catherine, that you helped us understand a little bit about the differences and what AI by AI is. So it can be argued that there are potential applications for AI by AI in the healthcare space, specific to interpreting in healthcare. Chris, how do you see this? What are some potential applications for AI by AI in healthcare interpreting?
Thanks, Vanessa, and thank you very much for the invitation to join this panel. This is really an honor. So our experience at Mass General has come to us from the provider side. When a lot of the ideas about AI and how to apply AI to interpreting in the hospital setting have come forward, they've generally been through avenues that go through the providers or senior leadership who get a call from someone that says, hey, I just found out about this new product and it is really cool and it's going to be awesome. We're going to save lots of money and we are going to, increase productivity, et cetera, et cetera. So then the conversation has started outside of interpreter services or the language access departments or teams. And when I started to get involved in this, the thought was out there that AI by AI could easily be launched on the inpatient setting of Mass General Hospital. Mass General is almost a 1,200 bed hospital. It's a tertiary acute care center. We are quite busy. And so the naivete with which this was approached was genuine in the sense that there was this desire to fill a gap that existed in providing services to inpatients because people weren't always calling to have interpreters come to interpret for encounters that were not lasting very long, or if a nurse was coming in to do just a check-in for a pain scale or something simple like that. Thankfully, because of the relationships that we established, we were brought into the conversations. And, I had to approach these conversations, first of all, from a position of being neutral about what my preconceived notion or judgment was going to be about the technology. Because at first, I sort of vomited in my mouth and then got very anxious and was stumbling all over myself. And so I said, okay, Chris, take a few deep breaths and let's hear what they have to say. So I remember walking into this room. There were people from these vendors that I'll talk about a little bit later, and they had this really big notion, and I had to break it down into smaller questions to help them to understand what interpreters do. But then, as I listened to their presentation and what the gaps are, some ideas started to come into my own head about how can, and Catherine, your presentation was very helpful to me in drawing those distinctions between, okay, what is AI generated, what's assisting interpreters, because for me, that was the line. How do we support or assist interpreters in doing their jobs? But also, where could AI by AI effectively be used? And here's a couple of situations that we came up with. The first was food and nutrition services. I can't tell you how many menus we have translated and how many times interpreters go to our patients' rooms to interpret for food and nutrition services as they're just trying to place their food order. People can't find the translated menus. Nobody knows that we have them done in 6 languages. And so they're struggling to get their food order in, or even understand just some basic dietary restrictions. And I thought, here is an opportunity. I have no idea how it would work, but here's an opportunity to fill a gap and provide excellent service to our patients who speak languages other than English. It would be considered a low priority area, but what if you bring a piece of food to a patient who has a food allergy? They do not speak English, and an interpreter was not partnered with in that situation. So it can create significant issues for the patients. And also from the interpreter's perspective, they say, these are great, I'm glad to help, but I feel badly because there are other encounters and situations that my help might be needed in more. That might be more of a priority. And the other area that we thought about was, appointment reminders. I can't tell you, even for as well-intentioned as we are, and as we try to implement all of these changes with phone calls and text messages to patients, even though their languages are indicated clearly in the medical record, they're still receiving these calls in English. Here's another area where can AI make a contribution to this area? And so having those conversations with the providers who initially brought up this idea and then followed through with a research protocol has been helpful to kind of defining what is the difference between a clinical conversation that has to be protected and the integrity of which must remain intact, versus a lower priority, non-clinical conversation that we could test AI and see what the effectiveness is in those types of situations. I know I've droned on and on here, but so that's kind of my in a nutshell for that.
That's incredibly helpful. And for folks who don't know Mass General, it's a very large organization with a very robust and well-established in-house language access program with all the modalities.
Yeah,
so you're providing in-person, you're providing video, you're providing phone, and yet you were able to identify gaps and areas where AI by AI could still be helpful in closing those gaps.
Yes.
Very interesting. Cindy, I saw you nodding along and agreeing. How do you see the potential applications for AI-generated interpreting in healthcare settings?
Well, I had to laugh when Chris said that when they first came to him with this, he kind of threw up in his mouth and had to control himself because, I think for many of us who work as interpreters, we also kind of go, wait a minute, there's a lack of understanding of what's involved. So I'd like to share two things. One is a thought I have overall, and another is I'm here on behalf of the National Council, and I wanted to share kind of our response to this because we wanted to kind of get out ahead of this. So my overall thought is, I think whether you think AI by AI will be helpful in AI generated interpreting depends a lot on what you think the role of the interpreter is. I think there are some parts of what interpreters do that maybe an AI in some languages might be able to do okay most of the time. But as those of you who know me and have taken any of my trainings, I think that there's a lot of things that interpreters do that an AI isn't going to be able to replicate. And so part of our problem with providers coming with us and saying, oh, look, here's this great, we could just use the AI. It's because they don't realize everything that the interpreters are doing in order to facilitate understanding and communication. But let me tell you a story. So a couple of months ago, end of June, the National Council was called to our attention that there were some companies, some language service providers who were actually aggressively marketing their services and claiming that they had an AI product that could completely replace all of the human interpreting and translation services. So what they're arguing is, contract with us. You don't ever have to contract with an interpreter again. Get rid of all your other LSPs. No worries about translation. Our AI is going to handle it all in all languages for all types of encounters. And if you went on their website, not only did they do that, but they were also claiming that their AI met all national standards, including Section 1557 regulations. And if you don't know what that is, email me. Section 1557 regs, that it complied with the with Joint Commission standards, that it complied with the national standards for National Code of Ethics for interpreters in healthcare, and the national standards of practice for interpreters in healthcare. And we felt that this was a pretty egregious claim. And at the same time, we realized that, there's a lot of, I just saw in the chat, Miles says, was that company also offering real estate packages over top of the East River? One wonders. And yet they're not the only ones making these kind of claims. And as you all know, there's a lot of administrators in hospitals out there who are responsible for contracting with the outsourced language services for their organizations, who are not very knowledgeable about language access. They're not a Chris Kerwin. I wish we had a Chris Kerwin at every hospital and clinic in the United States. Unfortunately, he doesn't want to be cloned. So, Chris, you're letting us down. Anyway, we were concerned that there would be people who would just buy into this marketing. And so we decided that at this time, the best thing that we could do as a council would be to put together some questions that we felt that hospital administrators ought to ask if they're going to seriously consider this. So can I share my screen, Vanessa? Is that?
If Salma makes you a co-host, you should be able to share your screen. There you go.
Okay.
Excellent.
So if any of you are interested in reading this, and I hope you all do, this is just a 3-page document. We kept it short because we know that people aren't going to read something that's 25 pages. It's up on the website of the National Council, and I'm hoping maybe Andy will put that link in the chat. But what we decided to do was to produce, as I say, a series of questions. And many of these were based very strongly on the SafeAI guidance, the guidance that came out of the nonprofit initiative SafeAI. And I know that that link has already been put in the chat, and I would strongly recommend you all take a look at that too. This one's a little bit narrower. This one looks specifically at just healthcare organizations thinking about just the AI-generated interpreting for use with patients. And we divided our questions into 3 areas. Some were questions for a healthcare organization to ask internally. So they're asking this to themselves. And it has to do with things like, how do we make sure that patients know that their interaction is being interpreted by a machine? Are they okay with that? And if they're not, can they opt out? Again, remember, we're thinking here about AI-generated interpreting for clinical interactions. Okay, this is patient talking to doctor. We also wondered, AI collection and storage is going to require that conversation be recorded, basically. And so what is a patient okay with that? Having their healthcare interaction with their doctor recorded? Again, how can they opt in or out of that? How is all of this going to integrate into staff workflow? Because we all know if something takes too long, the staff just don't use it, right? Is there a protocol for being able to switch to a human interpreter in the middle if it's just not working? How are we going to document that we used an AI-generated interpreter? I mean, and that becomes really important for legal setting. First of all, to document that there was an interpreter available, but to document that it was a machine interpreter. What are we going to do with site translation? That's the same problem we have with, any kind of remote interpreting. How are we going to track errors? How are we going to be able to identify the regional dialect variations so that we get the right AI interpreting product? Okay, so there were questions for an organization to ask internally. Then there were questions for a vendor to ask of the vendor. And these were kind of into 3 different areas. One was available languages. So here's the thing about AIs. As you all know, AIs are trained based on massive amounts of examples, which we call a corpus. And there are big corpuses. There is a big corpus, for example, for Spanish interactions, right? But that is limited to a small number of languages. There's a lot of languages for which there is not a big enough corpus or any corpus in order to effectively train an AI. So you have to ask, when people are saying, oh, this will work in any language group, you want to ask, really? How did you get that for Swahili? How did you manage to get this working for Hmong? There's no significant corpus to train the AI on. Particularly worried about those low resource languages. What about regionalisms? Can the AI hear all the different regional dialects? This is not, the kind of conversations that we have in healthcare are quite diverse. And they're often very nuanced. And we have people using different dialects. As a Spanish interpreter, I can tell you that I've sometimes had patients, for example, who speak Cuban Spanish that I can't follow. And I'm wondering, is the AI going to be able to pick up on all of these different regional dialects? How are they training for those? Then, because we had these companies claiming that they complied with the National Code of Ethics and the National Standards of Practice, we went back to the National Standards of Practice and said, okay, let's look at everything in there and see if there's some questions that need to be asked. How accurate is the AI? Okay. Has it been trained on discourse and terminology pertinent to healthcare? Okay. Other questions. How does it recognize and replicate register, style, and tone? Tone of voice. All the interpreters out there know tone of voice is critical. Is the AI going to pick up on that? The pre-session. We know that qualified human interpreters conduct a pre-session so that they know everybody understands the goals of the encounter. Is an AI going to do that? Can they ensure alignment with the goals of the encounter? We know that a pre-session also assures that all parties will know that they should address each other. They will understand that everything's going to be interpreted. I mean, these sets up the goals of the interpreting, right? Is the AI going to do that? Question. Qualified human interpreters manage the flow of the conversation. So if somebody looks like they are, if a speaker doesn't pause, they go on, human interpreters have a way of handling that. How's the AI going to handle that? Is it going to switch to simultaneous? Is it going to be able to handle, large segments of speech? Qualified interpreters monitor their own production and correct errors. Is the AI going to self-monitor? Human interpreters can intervene when they feel that the patient or provider are not understanding what the other person is saying, but they are not asking. Is the AI going to do this? How are they going to accomplish that? And if there are errors in interpretation, who will be held liable? And this is a big issue because AIs often don't pull from just a database from one company. They're pulling from databases, multiple databases. And so if there's an error in the interpretation, then who's liable for that? The company that is selling the AI? The hospital? Not clear. Human interpreters are constantly monitoring themselves for personal biases. And, and we all have them, right? Well, so does an AI because it's learned all the biases that was in its training set. So are there biases in the training sets? How are they going to address that? Human interpreters will identify and call to attention misunderstandings based on culture. Is the AI prepared to do that? Human interpreters are able to make adjustments that will accommodate maintaining respect for the patient, right? They'll encourage people to address each other, even if the provider starts out by saying, tell her or tell him. Again, how's the AI going to handle that? We know that interpreters, in the case of a perception that the patient's health and well-being is at significant risk, immediate risk, human interpreters will speak up. Is an AI going to do that? And finally, we know that human interpreters are constantly getting continuing education to keep up with new terminology, procedures, technologies. How are they going to continue training the AI? Are they going to keep up with what's new in medicine? So those were all of the things regarding the standards of practice, the code of ethics. As you can see, I'm a little bit skeptical. I'm quite skeptical, but I'm trying to I'm trying not to be prejudgy, but I think these questions need to be answered.
Mm-hmm.
The next,
and I do want to jump in and say that when this guidance came out, I opened it very excited as a career-long member of NCIHC. I said, "Ooh, NCIHC has an opinion." And then when I looked and I read through it, I said, this is not a position paper. This is a series of questions. But as I considered them and meditated on them, I realized these are very good questions. And by asking these questions in our health systems to prospective vendors, we can really uncover, what's underneath the advertising, what's underneath the claims,
and what backs it up. So if
and
a
what
place
backs it up. Yes.
So if a person comes in and says, yeah, our AI is 70% more accurate than a human interpreter, you want to ask, based on what?
Mm-hmm.
Do you have a study that shows that? I'd like to see the study.
Mm-hmm.
And oftentimes they don't. These are just claims that are being made. I know I'm going on too long, so I'll finish up real quickly. If compliance with federal regs, we have to ask, how does this AI comply with Section 1557 of the Affordable Care Act, the new regulations that came out early this summer? In translation, it says clearly that machine translation must be reviewed by a qualified human translator. Not so clear what the guidance would be under interpreting. We want to ask questions about quality assurance. Again, how do we get user feedback? Is there bias? What if it's not working? Can we get a human interpreter in the middle somehow? Another question at the end is, who owns the information? Because we know that in order for AI to work, the interactions are being recorded. Who owns that recording? How do we keep that safe under HIPAA? If the vendor owns this, what's the vendor going to do with that information? I mean, I think these are all questions that need to be answered. So,
absolutely.
So all of you can go read. Sorry for going on and on about this, but I wanted to share with you some of the questions and concerns that we have at the National Council. And the answers to this may change over time because, as you know, AIs are constantly being developed and improved. So the answers today will not be the same as the answers a year from now. But I think they're all questions that need to be asked.
Absolutely. So these are 17 questions to remember, to bookmark, to print out, to have as a checklist when you go into those boardrooms like Chris did to meet with those prospective vendors or even before. Now, I want to come back to you, Chris, because you were able to determine a possible use for AI by AI in some aspects of your healthcare environment there, and you were able to do a pilot. What can we learn from pilots of AI products in healthcare?
So the interesting context behind the pilot almost sounds like the beginning of a joke. 3 surgeons walked into a room and had a brilliant idea to resolve all of the language access problems that Mass General Hospital faced. They were wrong. So what happened was they began their pilot, and after they had begun to vet their AI, which was called the Ambassador app from Waverly Labs, they had gotten some senior leadership buy-in and were moving forward. They then contacted me because they got in touch with me through various channels because of people that I know. And so I got together with them. What was interesting about what they had to propose with this Waverly app was it was a cellular phone-based, smartphone-based application that would do a real-time translation through a Bluetooth headset that both the provider and the patient would have. Their initial proposal, as I had mentioned, was to introduce this throughout the inpatient units at Mass General for nursing. And that would resolve all of the communication issues for nursing. When I heard this, my brain got a little bit overloaded because I was saying, first of all, there are so many issues even before you get to introducing this to nursing. But as we went down the path of saying, okay, well, let's take a look at this just in and of itself first. Before we jump to a location, let's take a look at the technology. So as we started to use it with ourselves, it was fair. I would give it a C. Then we had to go to information security in order to vet it for things like Cindy was mentioning, like, is it HIPAA compliant? Information security found it was not HIPAA compliant. We could not locate it on our own servers, so therefore it had to exist on servers outside of the institution. And I know these are all technical aspects, but in terms of the protection of information for our patients, it's a tremendously important thing. And that's why the people in information security do what they do, because they're there to protect that information. So after several conversations, we decided that this was not going to be the appropriate pilot for us to follow through with. And as I had conversations with the surgeons, and we have this group called the Healthcare Transformation Lab. And what they do is they sponsor a lot of research studies and innovations in healthcare. And so the surgical resident who was the principal investigator on this was a member of the Healthcare Transformation Lab, which is really wonderful and really provides money to follow through with certain research studies. So he went and looked for another product, and he quickly found one, and the product is called Translate Live. This is sort of what Catherine was describing in terms of it's a voice to text in the source language, then the text is translated to the target language. It appears on a tablet for the patient. Then the tablet speaks the message. So it voices the message in the target language. It was a very interesting product. We were able to take this process sort of from the very beginning because we were all now on board. So the conversations that were happening between, the three surgeons and the different other departments that were joining us really they were more comprehensive and broadening our perspective. AI is here, it's not going away. So how we engage it becomes crucially important to the applications that we use it for in our local healthcare institutions. So we started to look at the application, and one of the things that I wanted to show, I will be transparent here. I wanted it to fail. That was my implicit bias. I said, okay, we're going to put this through a standardized test that we had developed at Mass General that we used to deliver to applicants who were going to be interpreters at Mass General. I was going to, from every language group that I had on site, I had one interpreter come to be the patient. I was the provider, and we had a rating system that was quite intricate. It was the same rating system that we used for our interpreters when they were applicants. And so we went through each language and we graded the very same script in each language. I thought it was a thorough and fair assessment. As you can imagine, it did pretty well in some languages, in Spanish, French, Portuguese, and Italian. It did okay. It earned between Spanish, actually Portuguese was the highest. It scored about an 88%. Spanish was around 87 or 86%. And then the percentages went down from there. When it came to Mandarin, Cantonese, Arabic, we also did Russian and Khmer. Those languages all scored quite lowly, right around the 70 and 60 percentile. So when I brought this information back to the group, and this again was very specifically clinical conversations, it helped them to understand that this was not something that could be used in specifically clinical situations.
Chris, can I ask a quick question? Those
Certainly.
percentages, at what level would you accept a human interpreter?
So we, on that same assessment, we require an 85%. They're very lengthy assessments. So the 85 percentile, I want to say there's around 200 questions, not 200 questions, but 200 points that we give for phrases and different sort of aspects of sentences and things like that. Does that make sense, Cindy?
Yeah, absolutely. So basically what you're saying is in 2 language groups, the AI did as well as an interpreter, you would hire a human interpreter. And the rest of the languages were if a human interpreter had gotten that score, you would not hire them.
They would not be working at Mass General, I can assure you.
Okay, thank you. I just wanted to see how it compared to the human. Thank you.
Yeah. And again,
I'd love to ask this, Catherine. I mean, I'm probably asking questions, so I didn't. Just one other question around that. So, this is based on tests where the humans and the machines do well with linguistic equivalents, like message transfer. But does the test include any components such as intervention, identifying errors, application of ethics, or was this simply the level of the linguistic transfer? Because I think that's where we also get these equivalencies where you could get that looks great, but then there is no other way to test for the rest of the interpreting skill set. So I was just curious how you handled that. It's fascinating pilot.
That is correct, Catherine. There was no way to assess for any of those other aspects. The one thing we did test it with was I have an interpreter from Argentina, and when he is speaking with his compatriots from Argentina, his accent is very thick. So I asked him if he would play the role of the patient and use a very thick Argentine accent, which he did. It did not do as well because there was an option to select different types of Spanish. Argentina was one of the options which we selected. It did not do as well as the initial 86%, but it was right around 83 or 84%. So it was close, but the accent definitely was not, it wasn't to the same standard as the other languages. Okay.
So Catherine brings up a great point, and we're coming to that about the other things that interpreters do, the myriad of other things that go beyond message conversion. But before we get there, I just want to pause and point out how easy it is in a healthcare environment for decisions to get made about language access with no one from language access involved in the decision-making process. And that's what was happening at the beginning when Chris became aware of these conversations. And it reminds me of something that the civil rights activist Shirley Chisholm used to say. She said, if they don't save you a place at the table, bring your own chair. And Chris, I know you've been bringing your own chair to these decision-making conversations for over a decade at MGH. If you could just backtrack a little bit, how is it that you are able to be involved in the decision-making process at MGH? As these conversations happen, how is it that you are able to be a part of them and to walk them back and to insist that nothing should happen about us without us?
So I've been at Mass General for 18 years, and I will say that it's taken that long to cultivate those relationships. I have been very fortunate because I am a white male. It allows me into rooms that other people do not have access to. I have a particular understanding of justice, and I also can be diplomatic, but I want to help leadership understand the importance of this. And sometimes hearing it from someone like me helps them to listen a little bit more careful. That's sad. It's very sad. But unfortunately, it's part of the truth. What I have found is that cultivating allies becomes the key to getting that invitation to that table and respectfully listening and responding. You know, I've had surgeons send me a text message, Chris, I need a Spanish interpreter, and they have my personal cell phone, you know, and it's okay. I didn't respond. Don't ever text me on my personal cell phone to ask me for a Spanish interpreter. That's ridiculous. I said, you know what, doctor, hold on 1 second. I'll see what my coordinators can do. Those little things go a long way. Mm-hmm. But it is about cultivating those relationships and truly being a part of the equity movements at your local facility becomes a great way of getting in to a group that can be supportive and lead to other open doors.
Absolutely. And in many ways, it's a fight for our own existence within a healthcare institution. You're helping your team, justify their existence in-house by involving them in the health equity work, by involving them in pilots like this, by allowing them that permission to be the vetters of something that's being suggested or proposed. What does it feel like to them? What input did they have in the design of the pilot? What comments did they share with you about the experience of vetting this essentially an app? What did they share with you that you can share with us from the interpreter's perspectives?
They were excited and scared all at the same time. Excited to be part of an effort that would look very carefully and very seriously at this type of technology. And very scared because looking down the line, they're drawing those conclusions that the companies that Cindy was referring to, hey, we can replace all of your interpreters. And that is the mentality that is, I think that some on my team had. They know that I'm an ardent advocate on their behalf and that we also have secured, it's taken a long time. It hasn't always been the case, but we have secured such incredible support from senior leadership that they understand the importance of language access and what a contribution our team has made to the delivery of care at Mass General. Mm-hmm. Excuse me.
That's
could I also add in there? I think it's very important. One of the reasons that the National Council's response to this was a list of questions instead of just an out and outright, you guys are nuts, this isn't going to work, these claims are ridiculous, is that I think it's very important that people who come with this excitement about AI don't perceive us as being just anti-technology. And Catherine does a really wonderful job of emphasizing, look, this is where, AI has been good in translation. I mean, I don't think there's probably any professional translators that don't use machine translation to do a first draft, and then they go back and fix all the mistakes. I mean, it's really improved the efficiency and the speed at which translators can work. So as somebody in that field once said, translators are not going to get replaced by machines. They're going to technology. They're going to be replaced by translators who know how to use the technology. And I think if they perceive us as being open to the technology in an appropriate way and open to piloting and trying out new things, I think that they will then have more that they will be willing to listen to us when we say, listen, here's the limits. Here's the places where it's going to work. Here's the places where it isn't going to work. And, and Chris didn't just say, well, in my opinion, it's not going to work. He did research. He did a little study. And again, for people in healthcare, especially doctors, having, that kind of research is, that's convincing. So I think we can do a lot to make ourselves the people they want to come to figure this out. And if we are too what's the word I'm looking for? Where you just like immediate no, if we just don't even listen to the arguments or even try it out, then we'll get dismissed as being just there to save our jobs. And that's not going to be helpful.
So, Cindy, you mentioned research, and this is something we've talked about for a very long time. There's not enough research, particularly in healthcare interpreting, on all of the things that we do. And Catherine, you mentioned other roles. So I'm going to pose this question to the panel. What crucial yet understudied aspects of the healthcare interpreter role extend beyond language conversion to actually drive health and health equity? What are the things we haven't really researched yet that we need to look more closely at?
Catherine, you take that one.
You want me to take? I think you should start off on the areas that you think we don't have enough research. I mean, there's so many areas. I guess where I would start with this one is that our problem is that we rely on research from associated fields, often in health, especially in healthcare interpreting and in, the dialogic interpreting in a regulated space. So it's like, okay, there was some kind of setting done on patient equity or patient risk or patient, and then there's like this layered on bit around the language access. And it's very rarely driven by our own profession. We just really, in this country, don't have enough academic programs. We have lots of training programs. We don't have enough full-blown up to master's and PhD programs targeting interpreting to be generating that, which is where a lot of that research I think would organically generate. It's where it generates in Europe, for example. So for me, a lot of the research we get isn't even targeted fully into what we want to know anyway. And then we take it and we bend it to our uses because it's what's available, So I think that there's a lot missing. And the other part that I'd say that I feel is just our biggest, the tsunami that we just are constantly fighting against is one, everybody wants the universal translator from Star Trek in all languages that's invisible. And the tech companies want humans out of the mix. So, and those two things equate human understanding and meaning in communication to the words only, right? So then, and so we have this just juggernaut of public wish and demand, like what Chris laid out right at the beginning. Great, we're going to have a tool back in our inpatient. It's going to solve all of it because it's the universal translators here. And, and so that's our constant battle. And the invisibility of what we do, was really this huge Achilles heel. And yet we know also as humans that meaning in communication is mostly nonverbal, right? So I think we have, in terms of our research, beyond just the specific things that we all know interpreters need to do around brokering and intervening and monitoring for understanding and being that person that can point to a train wreck if the service is going to derail. It's just even beyond that, like how do we impact this conversation of whoa, like this AI is really going to be great when you can rely on, a pretty decent, high quality linguistic equivalency, which is why it is being already sold very proactively into conference interpreting, and why, right? Like you have a speech and it goes across and people get most of the meaning and there's not jeopardy there, right? Versus the human dialogue. So I guess for me, my rambling answer, and I'm going to let you go, Cindy, is like, I just think we really need to somehow build the guardrails around the full complexity of human communication and where language fits in that, and that we have to really help people understand that these tools are, a word, it's a linguistic equivalency, it's not a communication equivalency, if that makes sense. So that's my comment.
Absolutely. Anecdotally, a friend of mine who runs a language access program in a hospital was interviewing one of those tech companies that's making big claims about its AI by AI product. And he asked, well, what about the other things that interpreters do? And the sales rep stopped and said, the other things interpreters do? Oh, you mean that culture stuff? that culture stuff. So I want to stop there a moment and dig a little deeper, maybe with Cindy. What are those other things interpreters do that have not been well studied, but we know they drive health and health equity in our local communities? That culture stuff. Tell us more about it. Oh, you're on mute.
Yeah, I have to say, I've been after us in the field for like decades to try and document the other stuff that interpreters do, even if it were something, and this could be done internal to hospitals. You could have, your interpreters won't like it, but tell them it's to save their jobs, right? For 2 weeks to document everything that they do that isn't strictly linguistic conversion. Make a list. Just after every appointment, stop for a minute and just write down everything you did that wasn't just linguistic equivalent, which I know is the linguistic equivalent is hard enough. But what about making the patient feel more at ease? Being that voice, the only thing that they can really understand and connect with. What about wayfinding? Especially in-person interpreters, do an enormous amount in helping patients figure out where to go. And then all the things that are in our training programs about, stopping when we've perceived that listeners are not understanding, raising that red flag, asking for teachbacks, intervening if we feel that there's a cultural issue at play, choosing our words carefully based on who the patient is. We say that, interpreters don't lower register. Well, wake up. A lot of interpreters lower register because you can't be constantly telling a provider, please speak in layman's terms. You can do that once, you can do that twice. After a while, it's too invasive. And so interpreters kind of look over their shoulders and hope nobody notices, and they lower the register so that the patient can understand the meaning of what's being said, right? There's a lot of these things that interpreters do to make the communication effective. And I think that there's some things that we could do as a field to try to highlight this. One would be more research. And, you don't have to be a PhD to do research, right? You can do research with a high school diploma. We used to do research in Bolivia with rural farmers who had gone through first grade. Okay, right? So you don't have to have an advanced degree to do research. All you have to do is think about, for example, let's ask the interpreters to document everything they're doing that isn't specifically linguistic equivalency. The other thing is, I have noticed, and because, I'm old, right? See how the gray hair is. I've been in this field a long time, and I know that as we've moved more towards remote interpreting, online, VRI and OPI, which have a wonderful place and are really important parts of providing effective language access. The more remote the interpreter gets, the harder it is to do any of these other roles other than the linguistic equivalent. And, I had somebody on a call yesterday telling me that if you're interpreting over the phone, you really can't do anything other than just the linguistic conversion. So the more that we, out of convenience, limit what our remote interpreters can do, the more people get this idea that all we do is a linguistic conversion. And part of this problem is that the remote, somebody's going to send me a nasty gram about this, and I apologize up front, but it has been my opinion, my observation, that the companies that are providing remote interpreting, most of them would love it if they didn't get any complaints from the client, right? And the way you do that is you give the doctors whatever it is they want. And doctors, generally speaking, don't like it to have an interpreter say, I don't think the patient understood. Could we have for a teach back? Because it slows them down. And so remote interpreters often get told by their companies, don't do this. Don't intervene. Even if you think nobody's understanding, not your problem. Don't intervene. Then the client won't complain. And not all companies are like this, but I have perceived that seems to be a trend. So would these companies be willing to educate their clients to say, you know what, if our interpreters perceive this, they're going to mention it. If our interpreters think somebody didn't understand, if our interpreters think there's a cultural issue at play, they are empowered to do this, and we back them up. Would the company be willing to back them up? So it's a discussion that we need to have. The more that we can highlight what a human interpreter can do to really improve the quality of the communication in the healthcare interaction, the more people will perceive when we need human interpreters, and when the patient's ordering lunch, maybe an AI interpreter is all we need. That's just fine. There's a limited number of choices, and there's a limited number of things people are going to talk about. But maybe not the same as when you're telling somebody that they are terminally ill or that their baby is going to die.
We absolutely hear this anecdotally from interpreters who work in the field in person and remote as staff members of hospitals or as contracted interpreters. It could be argued that it is perhaps easier to view oneself as a practitioner and a member of the care team if one belongs to the same institution and is viewed by the institution as a member of the care team. So yes, absolutely, there needs to be more research done, but also more of a consensus around the role of the interpreter, a role that should transcend modalities and not be limited by specific modalities. Now, I want to come back to Chris. Chris, we're all very curious about how your pilot turned out and whether or not you've done any implementation.
So we decided to go with only 2 languages on the Translate Live device, Spanish and Portuguese. We determined that no clinical areas would be involved. Rather, we would target the staff at check-in, and we also had one specific use case in the cardiac rehab center where patients are on treadmills. It's a 90-minute appointment, and my staff go up there all the time to sit there to interpret, how are you feeling now? I'm fine. And they stay there for 90 minutes and don't interpret probably for 89 of the minutes. So we tested it with the treadmill noise in the background. We tested it with people on the treadmill, and it actually worked really well. And so that was one area. The MRI area was another area. That's a problematic area because obviously you can't bring anything into the MRI machine. You have to use a speaker. It gets really challenging. We chose not to use it in the control room, rather at the check-in desk. We also targeted pediatric surgery, again, for the check-in desk, because sometimes there are some questions that are asked. It's mostly demographic questions and simple questionnaires. And the last place we went to was our main lobby. This is an area where we see generally about 60,000 people come into the main entrance at Mass General daily. So people are constantly coming up to the front desk asking for directions here and there. So just jumping to the conclusion, we have had very bad results in every area except for the front desk. The front desk has been hugely successful because of the accuracy of go down this hallway, take a left, and then take your first right.
Limited,
pretty
the limited amount that needs to be, limited variety of speech, right?
Exactly. And you're going to go to the 3rd floor on the B elevators. It's pretty straightforward. They have really loved it and they've used it well. All of the other areas have not used it They forget it's there. It's sort of the typical thing. The cardiac rehab experience went very poorly because a nurse decided to do medication reconciliation with the patient via the device before they got on the treadmill. And when the patient had responded, the interpretation was something like, I am with my girlfriend in the middle of the field. The nurse looked at it and just shut it down. And of course, they have
And
not
they won't use it after that.
And so they stopped using it on the treadmill because of what happened at the medication reconciliation. So we're actually in the process of trying to do another phase of the pilot to target some other areas with higher volume for patients who are Portuguese and Spanish speaking at the front desks. But interestingly, it has not been a really successful pilot, except for the fact that, and I reiterate this to the team all the time, even though the results have been poor, we know why they're poor. So that actually gives us information in where this does not work. And that's okay, because maybe we can shape this to find another area where it will be successful. And in terms of the languages, it was not expanded to the other languages just because of the scores that we saw on the in our tests. However, some of the clinics in difficult circumstances have used it for Arabic or for Chinese for smaller sort of conversations at the front desk, and it has been pretty successful, but they have not used it for those languages.
I love that point, that a successful pilot does not necessarily lead to implementation. A successful pilot tells you what you can and cannot safely do with that particular product. Now, in my own conversations with tech developers, I did have an interesting conversation with a developer who said, well, I have an AI by AI product, but if anyone gets stuck, they can always press a button and conference in a human interpreter. And my question was, well, who gets to press the button? Who gets to say, I feel that I'm stuck? Is it the nurse? Most likely, given the power dynamics in healthcare, it would be someone who works for the hospital versus the patient. And that brings me to a question from the audience. I see it here in the Q&A from Crystal Smar. Crystal is an early career researcher who has an interest in this topic. So maybe there's a connection
Crystal,
to be made.
Call me. There's so many good topics you need to be researching.
Crystal is asking, how do we assure that patients are included in the human-centered design process as well? And I'm going to open this up to all of you, to Chris, to Catherine, to Cindy. How can we get patients involved in these pilots and in the design of these products?
One of the things that we were able to do is we did a red cap survey for the patients after they used the device. At first, the three surgeons walk into a room and they develop a survey that's about 200 pages long. So we said, no patient is going to ask how to get to MRI and then do that survey. So we've cut it down. Very, very few people have taken the opportunity to do that, even though like a gift card was offered. But we also took the email addresses. If they didn't want to participate in it, we took their email addresses to email them the survey and ask for some qualitative feedback. I think that's one way of involving patients in this process.
I guess I would jump in here. I think it's an excellent question. It's not going to happen by any of the tech developers in any meaningful way. Partly just for for many, many, many reasons, but even just pragmatically, where the access is almost impossible in that way. I think it has to come from what Chris is describing. It needs to come from teams inside hospitals, inside healthcare facilities that are putting a committee together and actually tasking people with new kinds of jobs and tasks to really find this out. Like if you're really going to have the patient in it. And then the final thing I would say, I've had a lot of experience trying to survey indigenous populations. We're involved in a really big survey inside Mexico, trying to determine just which languages were being interpreted.
Oh, wow.
And the only time I've ever seen a process of inclusion work is when you actually you go the labor intensive route of working with the people who have access to the patient communities who don't speak English. You create moments where people can come into anywhere, a cafeteria, a setting, a meeting, and you have people there who will sit down and fill out the surveys with them if it's going to be survey, or you do some kind of focus group setting, same thing. So the answer, I think, is a hard, realistic. It takes a lot of human touch. You can't send out a survey in 10 languages and expect anyone to fill it out. This would be true for also trying to, outreach the deaf and hard of hearing community effectively. You have to actually do the time to relationship build so you can get people in a room. And then if the tool needs to be a survey, you're actually sitting down with them and asking the questions and filling it out for them if need be. And all of that requires creating enough safety and trust that those communities will walk into a room and feel like they can give you information that doesn't endanger them or their immigration status in some way. So I think it is a gigantic heavy lift. And I just don't think, but that is what works. That's the only time I've ever seen any process like this work, is if you do all of those extra things. So.
And it has to be done in local communities, everywhere, really. Equity starts locally. Yep. So I want to come to the final question that I had prepared, because it's something that concerns me. In the age of AI, how can hospital language access program administrators and other healthcare leaders continue to foster cultures of language justice within their institutions? How can we do this in this age of AI?
I can start and then everyone else can finish, because I'm always going to be the big picture person, especially so that, and to wrap this back around, as one of the co-founders of the SafeAI and Interpreting Task Force, the reason why that group got stood up so quickly was, one, because enough of us have been in this field long enough to have seen what happens when, like, translation did not respond to machine translation. And when interpreting did not respond to the development of remote interpreting, we did not bring it into the fold as we professionalized. And so now we have two parallel workforces. One has been highly professionalized and one has not. And so there is there was this urgency of like, oh my God, this is going to overtake us. And we want a group that's specifically targeting interpreting and not translation and interpreting, because of the real-time nature. So I just wanted to provide that context for the rest of my answer, which is, I think that if you're inside a hospital and you are the one responsible for standing up your services, the companies are selling you a rainbow unicorn interpreter and a rainbow unicorn service. 300, we've got 300 languages, 24/7. It's all equivalent. We can promise equivalent quality. Like, that is what our industry sells when you look at it from that side. And that's what people want to purchase. And that's what people are pressured to purchase so they can get the lowest cost. But I think AI is a real inflection point. There is zero way for clients and the end buyers, the hospitals, to really just lean on what LSPs are selling and are pressured to sell anymore. Like, the whole point of what NCIHC did with the guidance, which was built off of what the SafeAI Interpreting Task Force has been able to do so far, which was to do a big piece of research and create some initial guidance. Was precisely to get to say, hey, it's the accountability rests everywhere. And if you're going to put these systems into place, you need accountability. And let's try to make that possible for you. And the way to make that possible is, one, have somebody internally paying attention to this. Two, understand where the broad things that legislation are asking, transparency, accountability. We know it's being used. It is language compliant access. It's a HIPAA compliant, et cetera, et cetera. And then have a real decision-making tool like what NCIHC provided, like what is going to be coming out from CSA research next month, like tools that really help you create a decision-making tree for your organization that allows you to understand when you can safely implement, where you can safely implement this and where you cannot. But to me, it's this message of shared accountability and responsibility. It's not about ticking a box. You can't tick a box safely at all. I've got my remote service. I've ticked my language compliance box. It's like those days are over. I mean, I just think they're over, and I hope we can like embrace that and really do client education in a way we have not been historically able to do very well. So that's where I'll end. But that's my thought about that.
That's something I've always believed. A vendor is not your language access plan. It's a component of your multifaceted language access plan, which has to start locally. Yeah. Chris, what are your plans as the Director of Interpreter Services at MGH to keep building that culture of language justice within your institution, within your community?
So just to touch upon something you had mentioned before, I look at this in terms of what we do is mission driven, and who we serve are those who are most vulnerable in our society. So how we carry out our work, often on bare bones budgets, and we MacGyver our departments with paper clips and rubber bands. But the bottom line is the work that we perform is quintessential to healthcare because it's about delivering care to those who are underserved. Therefore, going back to that question you asked about the equity groups, having that relationship with diversity, equity, inclusion, and belonging folks at the institution becomes critical because it fortifies the mission. And when people can understand that there is a mission behind what we're doing, the purpose becomes clearer. And then the steps that we take to enact whatever that vision is has a guardrail. So even in terms of AI by AI, the guardrail comes in terms of this horizon of understanding, which is our mission. And I keep on emphasizing that to each of the groups that I work with, not necessarily in an overt way, but by helping them to understand what it is we're doing on the ground and why we're doing it.
And that's a beautiful piece of advocacy. There can be no health equity without language justice. So language access needs a seat at every health equity conversation table. Every table. Cindy, tell us more.
I have kind of three ideas I wanted to leave you all with. One is, I am not worried about hospitals like Mass General. I mean, they have Chris Kerwin there who is going to make sure that any process put in place is one that is going to best serve patients' interests and be amenable to the staff and be doable by the hospital. I mean, we have a gatekeeper there, and as I say, I wish we had Chris at every hospital in the country. So I'm not worried about that. I think there are some slippery slopes that, we need to be keeping an eye on. And I think somebody mentioned it in the chat, the idea that, well, we'll start to use it for this. And then, as we saw, the nurse said, oh, well, we're using it for the cardiac rehab. We'll just use it to reconcile the medication. Why not, right? That's why I get a little bit nervous, because we know that staff will start to try using it. Just like we know that even though we tell staff not to use Google Translate to send patient stuff home, they do it anyway, right? But the second thing I want to say is, as interpreters, we need to realize that we need to be very transparent about, number one, everything we do, not just the linguistic conversion, all that culture stuff, right? And also, we need to be good. Because if your average interpreter out there would only get on Chris's test would only do a 70, and we can get an AI that'll be 70, that'll be an 86% accurate, and the AIs are that much more accurate than we are, then we will be replaced. And I'm, glad to know that Chris has that bar at Mass General, and I am afraid that's not the case in a lot of places. We still have lots of stories about working interpreters who are just egregiously inaccurate. So, we need to pay attention to that. And the last thing I wanted to say is, as I said, I'm not that worried about the Mass Generals of the United States. I'm much more worried about all the other smaller hospitals who don't have the leadership that is aware of these issues, that gives importance to these issues. Hospitals maybe that are under extreme financial pressure, where they feel like they can't afford to pay attention to these issues, where there is no language access coordinator, where you have the people in procurement are the ones who are contracting for language services. They're the ones that order, the bedpans and the paper clips. And now they're going to order, how we're going to have interpreters. I worry about them. And so the only way that you get on their radar is through national regulations. So I wanted to let you guys know that in addition to writing these questions for hospital administrators to use, the National Council has also passed on information as well as links to all these websites that are advertising this stuff in what we feel is not a very honest way. We have sent that off to the Joint Commission, to our contacts at the Joint Commission, to our contacts at the Department of Health and Human Services, Office for Civil Rights, to our connections at CMS, which manages Medicaid, and to our great colleagues at NHELP, the National Health Law Program, because we feel that this needs to be on the national radar of the people in these regulatory agencies. And if you can think of anybody else that we ought to be letting know, then let us know.
We need to bring panels like these to the American Hospital Association, to America's Essential Hospitals, and to other groups that can get this information, this understanding, to frontline clinicians, to those surgeons that walk into the room with the bright idea on how to fix language access. And we're so lucky to have the three of you leading those efforts as well. So thank you, Catherine. Thank you, Cindy. Thank you, Chris. We want to thank Andy and Debbie, who have done excellent work in the chat. We want to thank our interpreters, Rose and Justin, who have done a phenomenal job bringing this conversation into ASL, and for the deaf community members who attended today and who are getting involved in the work of the Deaf AI, the SafeAI Task Force. So we encourage you to, when this recording comes out on YouTube, to share it widely, to share it with your hospital administrators, the people in charge of decision-making, with your language access leaders, if you still have them within your institution. And if not, step up and be that person, even informally. Pull up that chair to the table and make sure that nothing happens without us. Well, thank you so much for attending this OTR number 8. We invite you to our next episodes, which will come out. We've been hosting conversations on different themes about building language access infrastructure for 2 years now, and we hope to continue into the future. If you are doing a pilot like Chris's, please let us know about it.
Yes.
You can reach us at otr@ncihc.org. And if you have specific questions for panelists, please also send them to us at otr@ncihc.org, and we'll get them answered for you. Thank you all, and have a wonderful day.
Thanks, everybody.
Thank you.